Hello everyone, myself Rahul Dantalwar. My topic for this presentation is anti-rheumatoid drugs and anti-gout drugs. Anti-rheumatoid drugs are the drugs which suppress the rheumatoid process and bring about remission and retard the disease progression. But they do not have non-specific anti-inflammatory or anti-analgesic action. They are also referred to as DMARDs or SAARD. Rheumatoid arthritis is an autoimmune disease characterized by joint inflammation, synovial proliferation, and destruction of articular cartilage. It involves multiple small joints of hand and feet, which are preferentially affected. NSAID are first line of drug which afford symptomatic relief in pain, swelling, morning stiffness, immobility. Goal of drug therapy for rheumatoid arthritis: it ameliorated pain, swelling, joint stiffness. It prevents articular cartilage damage and bony erosion. It preserves joint function and prevent deformities. Drugs. First drug is methotrexate. Methotrexate inhibits dihydrofolate reductase enzyme. It has prominent immunosuppressant and anti-inflammatory property. Pharmacokinetics. Probenecid and aspirin increase methotrexate level and toxicity. Uses of methotrexate. Methotrexate is now the DMARDs of first choice, and it's a standard treatment for the most patients, including juvenile patients. Methotrexate is preferred drug for initial treatment because of its rapid relieving symptom. Active infection, leukopenia, and peptic ulcer are the contraindications. Also pregnancy, breastfeeding, and renal diseases. Side effects are oral ulceration and GI upset. Incidences of chest infection are also increased. Second drug is azathioprine. It is less commonly used and it's not combined with methotrexate. Other immunomodulators include sulfasalazine. It inhibits the generation of superoxide radical and cytokine elaboration by inflammatory cell. It's used as second line drug for milder cases or is combined with methotrexate. It exerts anti-inflammatory activity in bowel and it's useful in ulcerative colitis. Side effects are neutropenia, thrombocytopenia, and that occur in about 5 to 10% of patients. Next drug is hydroxychloroquine, also known as chloroquine. It's anti-malaria drug. It induces remission in about 50% of patients, but it takes long period for its effect. Bony erosion is not prevented. Mechanism of action is it reduces monocyte interleukin 1 antigen processing is also interfered, and lysosomal stabilization and free radical scavenging. Its uses are in milder non-erosive disease, especially when only few joints are involved. It can also be combined with methotrexate and sulfasalazine. Its side effects are renal damage and ocular opacity, reversible in case of hydroxychloroquine. Other side effects are rashes, graying of hair, irritable bowel syndrome. Next drug is leflunomide. It's contraindicated in children, pregnant, or the lactating woman. It's used as alternative to methotrexate and can also be added to methotrexate. Side effects are increased chances of chest infection and raised hepatic transaminases. Next class of drug is biological agents. Biological agents binds to and inhibit cytokines, especially TNF alpha and interleukin 1, but they do not arrest the rheumatoid process, though joint destruction may be slowed and bony erosion delayed. TNF alpha inhibitors drug includes etanercept and infliximab, adalimumab. They mainly suppress macrophage and T cell function. Quicker response is obtained. Susceptibility to opportunistic infection, including TB, pneumocystis pneumoniae, is increased because macrophages and T cell perform important role in combating bacterial infection, especially granulomatous infections. Other biological agents include anakinra, which is interleukin 1 receptor antagonist. Next class of drug is corticosteroids. Glucocorticoids are potent immunosuppressant and anti-inflammatory. Though joint destruction may be prevented and bony erosion is delayed by corticosteroid, long-term use of corticosteroid carries serious disadvantages. Therefore, either low dose used to supplement NSAIDs or high dose over short period of time in cases with severe symptomatic manifestation. Drugs used in gout. Gout is metabolic disorder characterized by hyperuricemia. Acute gout arthritis. It manifests as sudden severe inflammation of small joint due to the precipitation of urate crystal in joint space. It requires immediate treatment with strong anti-inflammatory drug without attempting to lower the urate level. NSAIDs, first class of drug used in acute gout. They are strong anti-inflammatory drugs. Example: naproxen, piroxicam, diclofenac, indomethacin can be used. They are quite effective in terminating the attack. Response is somewhat slower than colchicine, but they are generally better tolerated. Majority of patient prefer NSAID over colchicine. Naproxen and piroxicam, they specifically inhibit chemotactic migration of leukocyte into inflamed joint. Colchicine, it's neither anti-inflammatory and nor analgesic, but it specifically suppresses the gout inflammation. It does not inhibit the synthesis or promote the excretion of uric acid. Mechanism of action of colchicine is by it inhibits the release of chemotactic factors and glycoprotein. It inhibits granulocyte migration into inflamed joint, and this interrupts the vicious cycle. Dose of colchicine. Colchicine is a fast-acting drug to control acute attack of gout. Colchicine is considered diagnostic. However, because of higher toxicity, it is second-line option to NSAIDs. Side effects are toxicity of colchicine is high and it's dose related. Next drug is corticosteroids. Intra-articular injection of soluble steroid suppress the symptom of acute gout. Uses only when one or few joints are involved and in those not tolerating NSAIDs and colchicine. Systemic steroid cause renal failure. They should be avoided in renal failure cases, patient with peptic ulcer, and in those who do not tolerate NSAIDs. Chronic gout or hyperuricemia. When pain and stiffness persist in joint between attack, gout has become chronic. Its cardinal features are hyperuricemia, tophi, and urate stone in kidney. First class of drug is uricosuric drug. First drug is probenecid. It competitively block active transport of organic acid, mostly in renal tubules. Therefore, it's not used in a patient which have renal inefficacy. Net effect of probenecid on excretion depends on whether the secretion or reabsorption of particular organic acid is qualitatively more important. Penicillin is prominently secreted, hence net effect of probenecid is inhibition of its secretion, and uric acid is largely reabsorbed, hence probenecid inhibits its reabsorption. Probenecid is neither analgesic or anti-inflammatory. Probenecid is used for chronic gout and hyperuricemia. It prolongs the action of penicillin and ampicillin. Adverse effects are dyspepsia is most common side effect. Next drug is sulfapyrazone. It's gone out of disuse because of its gastric irritation and platelet aggregation. Uric acid synthesis inhibitor. First drug allopurinol. It acts as substrate as well as it inhibit xanthine oxidase enzyme responsible for uric acid synthesis. Allopurinol itself is short acting competitive inhibitor of xanthine oxidase, but its major metabolite alloxanthine is long acting non-competitive inhibitor of xanthine oxidase. Hence, plasma hypoxanthine and xanthine is somewhat increased and uric acid reduced in plasma. Xanthine hypoxanthine has higher renal clearance than that of uric acid. Uses of allopurinol. Allopurinol is first choice of drug in chronic gout. It can be used in both overproducer and under excretor of uric acid. Allopurinol therapy is generally long term. Tophi disappear gradually and nephropathy is halted. It's also used to potentiate 6-mercaptopurine and azathioprine in cancer chemotherapy. Caution should be taken while allopurinol as well as uricosuric should not be started during acute gout. Contraindications are pregnancy, lactation, hypertensive patient. Adverse effect, they are uncommon. Interaction, inhibit degradation of 6-mercaptopurine and azathioprine. It has complex interaction with probenecid, while probenecid shorten half-life of alloxanthin. Allopurinol prolong half-life of probenecid. Allopurinol can potentiate warfarin, theophylline by inhibiting their metabolism. Higher incidences of skin rashes when ampicillin is given to patient on allopurinol. Next drug is febuxostat. It is newer non-purine xanthine oxidase inhibitor, equally or more effective than allopurinol. It is a drug alternative to allopurinol. Unlike allopurinol, it is highly plasma protein bound. Side effect hypersensitivity reaction and are rare. Most important side effect is liver damage, and it's contraindicated in malignancy associated with hyperuricemia. MCQs. Question number 1. Woman present with pain, swelling and redness of knee joint and hand. There were associated complaint of morning stiffness with problem in squatting. Swelling spared the distal interphalangeal joint. The image of the patient hand is shown below. What is the most likely diagnosis? Here we can directly see that it's a case of rheumatoid arthritis, so option number A is correct. Question number 2. A 55-year-old woman is being treated for rheumatoid arthritis. Her disease has become much worse and new medication is added. After 6 months, she notes night sweat, weight loss, chronic cough and chest. A radiograph indicates a cavitary lesion. Which of the following medication was most likely prescribed for rheumatoid arthritis? Its answer is biological TNF-alpha inhibitor actually. So answer is infliximab, option B. The immunosuppressive effect of methotrexate is a result of its inhibition of which of the following? Option number A, that is dihydrofolate reductase. Question number 4. An 18-year-old man who is known to have non-penicillin producing gonococcal urethritis is given an injection of penicillin and probenecid. What is the mechanism used by probenecid that makes penicillin more efficacious? What penicillin do? Penicillin increase the plasma concentration by inhibiting the excretion of penicillin. So option number B, increase the half-life and serum level by decreasing the renal excretion of penicillin. MCQ number 5. Allopurinol is useful in treating gout because of which of the following property? Allopurinol inhibit xanthine oxidase and it decreases the production of uric acid. Hence option number C is correct. It decreases the production of uric acid. Thank you.